Good evening, all participants, doctors, physicians, the consultant physicians, practitioners who have joined us all across the India. Thank you so much for joining us and waiting for the sir to join. Thank you so much. Today we have with us Dr. Sukanto Das sir with us, and let me tell you, he's an author. He is a nephrologist, and many more. The honor to him. He has recently written a book on disrupted word, a mysterious virus which has shattered the humanity. So if you want to read that, you can go and visit the Amazon, and you will get all intricacies of the COVID-19 pandemic from its beginning till the recent development. So, sir has done his MD and DM nephrology. At present, he is working as the senior consultant nephrologist and renal transplant physician is in Amara Hospital, Bhubaneswar. He has, pioneer to initiate the renal transplant program at Amara Hospital. He has established the nephrology unit there. More than 10 years of experience he has, and more than 500 kidney transplant he has been carried out under his own expertise. So he has several publications on his name. I don't have time to go through each and every one, but he is known for publications. He has published his papers in national, international. He has been speaker for national and international conferences, and the conference which has recently happened, which is considered as one of the biggest conference. So he was the whole soul and organizing secretary of that chapter. So, and he is active member of Indian Society of Nephrology, Organ Transplant, American Society of Nephrology, International Society of Nephrology, and Indian Medical Association, and he believes in imparting knowledge. That's why today he could give time with his busy schedule, and the today's subject is, I would say, we required him because he has been a great help to guide us on this particular subject. So today, being the main division, pharma division, and the part of nephrology division, is going to discuss today with us the role of SGLT2 inhibitors in DKD, diabetic kidney diseases. And one more thing, this session is live on Facebook. Yeah, so if anybody wants to see it, you can go and see it on Facebook. You have given a link, so click that link. You can see on. So, sir, without further ado, please over to you. Thank you so much.
Thank you, Dr. Mangesas, for an extensive and a very kind and personal and intimate introduction. And I'm personally thankful to you. You have been always a part of each and every of my endeavors, and we have closely interacted in many sessions earlier. And thank you for putting in a word about my book as well. So once again, sorry for the delay. I had to rush in from the hospital, but thank you so much for waiting with a lot of patience. So before making you wait any further, I think today's topic here, I would just share this. So today's session is something related to diabetes, and today is 15th of November. Yesterday, that is on 14th November, we had World Diabetes Day, and the message for World Diabetes Day this year was basically education. Education is an important tool towards empowering and enabling patients as well as caregivers towards protecting themselves against the various adverse consequences of diabetes. We know that diabetes is a multisystemic disorder which has got its microvascular and macrovascular components. One of the most organ involvements in diabetes is the involvement of kidneys, and in other words, in common parlance, that we recognize it as diabetic nephropathy. So there was a point of time when we thought that diabetic nephropathy is an inevitable consequence of diabetes, but with change in time, we are having more and more defense mechanisms. At one point of time, we were defenseless. against the inadvertent progression of diabetes into diabetic kidney disease or diabetic nephropathy. But there are several agents with us available today, and today we are going to once discuss about one such promising group of drugs which in near future uh, have hold the promise of significantly transforming the outcome of diabetic nephropathy. So the topic today is SGLT2 inhibitors in diabetic nephropathy, and I'm here, Dr. Sukant,
Yeah.
your presenter today. So you see, diabetic kidney disease is one of the most important complications, and how it is characterized, just like any complication of kidney disease, any progressive kidney disease, it is characterized by a decreased glomerular filtration rate, and another important component of it is persistent albuminuria, which is an equally and almost insulting event in diabetic kidney disease. There are various factors which contribute towards it, which can be in the term of environmental factors or genetic susceptibility, and of course, certain metabolic and hemodynamic susceptibility in case of these patients. As I said, this diabetes, the very basic mechanism in diabetes is hyperglycemia. And hyperglycemia, how does it involve the kidneys? It involves there is glomerular hyperfiltration, there is increased angiotensinogen, increased angiotensin converting enzyme, and that is where the pathways that target renin angiotensin system are effective. There is another proximal tubular, and the role of proximal tubule, there is an increased SGLT2 expression. And SGLT2 is receptors that happen to be present in the S1 segment of the proximal tubule of the kidneys. And this is where we would like to focus our attention, and how inhibition of this SGLT2 would help us in reducing the progression. There are also, of course, increased renin, increased angiotensinogen, and increased tubular reabsorption of sodium. All these factors, if inhibited, uh, or if targeted at the right point of time, may delay the progression of CKD in diabetic kidney disease. What is the need of an anti-hyperglycemic agent? The first and foremost thing in diabetes is, even before we think about the various organ involvements and delaying organ involvements, the first thing in diabetes is focused on what you should do in diabetes, the control of blood sugar. A long-term glycemic control is the most important thing. Weight loss. Diabetic is a metabolic disease, and weight loss is weight gain is associated with insulin resistance. So losing weight and gaining of or fighting against insulin resistance is one of the important tools of diabetes management. And of course, renal protection. These two things, along with other agents, will together target as renal protection and long-term kidney protection in these patients. Now, coming to specifically, it's an extensive topic. So let's be more specific and then come back to the role of SGLT2 in glucose metabolism. The SGLT2 expression and activity of SGLT2 genes are upregulated in diabetic kidney disease. The renal threshold is increased in patients with type 2 diabetes. There is increased glucose reabsorption from glomerular filtrate and reduced urinary glucose excretion. Let me re-emphasize these points. There is increased glucose reabsorption from glomerular filtrate and reduced urinary glucose excretion. So that in a patient who already has a high blood sugar, this can only worsen the hyperglycemic condition in these patients. So what really happens is that activity of renin angiotensin aldosterone system, it causes efferent atrial vasoconstriction and glomerular hypertension in type 2 diabetes. And hyperglycemia causes afferent atrial vasodilatation in type 2 diabetes. So there is afferent atrial vasodilatation and efferent atrial vasoconstriction, increased sodium delivery to the macula densa. Now, action site of renin angiotensin inhibition and action site of SGLT2 inhibitors. These are the various sites in the tubule where these are the action sites of RAS inhibition, action sites of SGLT2 inhibitors. Now, SGLT2 increased sodium and 90% glucose. SGLT2 is actually responsible for 90% of the glucose reabsorption in the proximal tubules. So this is how the renal proximal tubule is situated. Now, what do we do when we block the reabsorption of glucose by inhibiting SGLT2 or what is the role of SGLT2 inhibitors? They block the reabsorption of filtered glucose in the proximal tubule. So there is increased urinary glucose excretion, and there is decrease of glycated hemoglobin, decrease in fasting plasma glucose, increase in endogenous glucose production, and was accompanied by increasing fasting. When these things go on, the SGLT2 goes on acting, then it obviously leads into certain metabolic consequences which are not uh, beneficial to the diabetic patient. That is why when we block, there is a decreased reabsorption of glucose and increased excretion of glucose in the urine. So here we have a picture which shows us the different mechanisms, the pharmacological roles of SGLT2 inhibitors in experimental models. Renin-angiotensin system component activation, renal inflammation, and when we inhibit the SGLT2, what does it do? It reduces hyperfiltration and it prevents molecular markers of kidney growth and certain fibrotic responses of proximal tubular cells, glomerular size, and as well as gluconeogenesis. So there are various mechanisms. The same mechanisms that actually give rise to increased progression of kidney disease, those mechanisms are reduced. There is also increase in GFR through the physiology of glomerular feedback, and there is possible reduction in hydrostatic pressure in Bowman space. Before any drug that gets used, one needs to get an FDA approval, and FDA had suggested that any drug that is intended for reducing blood sugar and any anti-hyperglycemic agent should have a cardiac safety at first. So the SGLT2 inhibitors, of course, had a distinct cardiac advantage, not only cardiac safety, they had cardiac advantage as well. Then, of course, they were gradually introduced one after another. So their various agents are canagliflozin, dapagliflozin, and empagliflozin. And this is an extensive chart which shows their dose adjustments, drug interaction. I'll come to it later on, but to be precise, these are the three common agents which are increasingly available all over the world. And once again, what do they do as far as the renoprotective effect is concerned? They reduce blood glucose and body weight. They reduce intraglomerular pressure. They attenuate diabetes-associated hyperfiltration and tubular atrophy, reduce the tubular toxicity of glucose, reduce albuminuria, serum uric acid without potassium abnormalities. So they do not cause hyperkalemia, which would have been a concern, especially with RAS inhibitors and all. It is not a concern in this case. They reduce blood pressure, especially the systolic blood pressure, because glycosuria doesn't happen as such. It also accompanied by a certain extent of natriuresis or increased excretion of sodium. So there is afferent atrial vasoconstriction and osmotic diuresis and weight loss. So all these things are very important. Diuresis can induce increased hematocrit and erythropoietin, reduce the workload of proximal tubule to improve tubulointerstitial hypoxia. We need to reduce the tubulointerstitial hypoxia. So diuresis helps here and then allows fibroblasts to resume normal erythropoietin production, thereby protect the kidneys. Long-term kidney outcomes are, these things all lead to a favorable list of long-term outcomes. One more slide which indicates what are the various beneficial effects, and not only the beneficial effects in terms of at the macro level, at the microvascular level, at the microscopic level, and at the level of cytokines. There are various harmful cytokines. All the adverse effects of diabetic kidney disease are carried out by a plethora of cytokines. These cytokines, especially TGF-beta, various growth factors, fibronectin, they are reduced, and NF-κB is reduced, and of course intercellular adenosine molecule is reduced, and monocyte chemoattractant protein is reduced. Similarly, reactive oxygen species, which is a very is a very notorious agent in causing the adverse consequences of CKD, that also gets reduced, and all these things are associated with the reduction in glomerular hyperfiltration. So There are various studies in animal models where the beneficial effects have been documented and the renoprotective effects have been documented. And these drugs can be combined. The good thing is that the studies have documented that these drugs can be combined with other renoprotective effects. First, for decades, we have had S inhibitors, ARBs, they still are important. And the good thing is that their additive effect, when they are combined with SGLT2 inhibitors, they both work in synergy, and they reduced cardiovascular endpoints. Various studies have shown that the primary endpoints, as far as cardiovascular, as far as renal protective, as far as the management of hyperglycemia, all together, they reduce the renal risk, reduce renal hyperglycemia, and they also delay the progression of chronic kidney disease. And what are the things? Another important agent in management of diabetes or diabetic uh, hyperglycemia and diabetes is DPP-4 inhibitors. So can we combine DPP-4 inhibitors with SGLT2 inhibitors? Yes, it's an absolutely important area of concern because they are both new agents and both are effective agents. So do we have studies? Yes, studies do document that when we combine these two agents, they also have got a synergistic effect. Similarly, GLP-1 receptor agonists, do they have an effective? Yes, these agents can also be combined with SGLT2 inhibitors, and these two agents also have got a significant additive effect and synergistic effect in reducing hyperglycemia and protecting, giving a long-term benefit to the kidneys, and also a good lipid profile or a favorable lipid profile in terms of and all these things together will translate into good cardiovascular outcome and reducing progression of CKD, reducing insulin resistance, and overall outcome for the patient. So once again, each and every slide, study after study, have shown. So some of the important studies that we must enumerate here. One of the earliest studies that had documented the renal protective, which was seen as an additional benefit, even though the earlier studies were not targeted towards showing the renal protection, but nevertheless renal protection was an additional benefit, almost something so significant that it could not be ignored. EMPIREC trial was ONSIS trial, CANVAS was also ONSIS trial, and DECLARE TRIMI trial. All these more or less were cardiovascular trials, but they did show that these drugs have got important renal protective effects, whether in terms of reducing albuminuria, whether in terms of delaying the doubling of serum creatinine, or of course, whether in terms of delaying the requirement of renal replacement therapy. So all these terms had a certain decrease in EGFR. So they had a long-term favorable outcome, but there was an interesting point where there was a certain decrease in EGFR, which was followed by a stability in the long term. So this is also an important concern. Maybe if I'm not able to tell it in subsequent slides, let me tell you, some of these agents can induce a certain decline in GFR, but that should not dissuade or discourage the practitioners, because after a certain dip in GFR, the GFR comes back to the steady state, and in the long run, the decline in GFR is reduced. EMPIREC trial and CANVAS trial, as I've just enumerated, DECLARE TRIMI trial. Another important, very important trial as far as the SGLT2 inhibitors is concerned is the CREDENCE trial. CREDENCE trial was done with canagliflozin, and it had showed that the composite of end-stage renal disease, whether the reduction in GFR or the doubling of serum creatinine or death from renal or cardiovascular events, all these primary outcomes and had a significant reduction. Similarly, major cardiovascular events had a significant reduction in as the evidenced by the other trials. Of course, they do have an additive effect of reducing, significantly reducing the systolic blood pressure, natriuresis, reduced atrial stiffness, reduction in body weight. The slide after slide will demonstrate how beneficial they are. Now, coming back to some of the individual agents, empagliflozin, it reduce the renal blood flow, renal vascular resistance, and it enhanced the glucosoric response, likely reflecting an increase in afferent atrial tone because of an increase in the distal tubular solute delivery in type 1 diabetes patients. There was no decrease in renal blood flow or renal vascular resistance in patients with normal GFR at baseline. Did they have an effective or beneficial effect on erythropoietin? Yes, due to stimulatory effect of SGLT2 inhibitors and renal production of erythropoietin, they did have a beneficial effect. They did have a beneficial additive effect on RAS axis as well. They did have a beneficial effect on the uric acid metabolism. So all these things together would suggest that they have got direct renoprotective effects and decreased albuminuria and the independent cardiovascular risk factors such as body weight and blood pressure, attenuates glomerular hyperfiltration, inflammation, and oxidative stress. These things and their additional benefit because of their synergistic action with RAS inhibitors, they slow the progression of diabetic kidney disease by reducing inflammatory and fibrotic markers induced by hyperglycemia or either of the two drugs alone. So it's a very vast topic. I think I just kept it limited to this much. Thank you very much for a patient listening. Thank you very much.
Thank you so much, sir, that you could touch upon the significance of SGLT2 inhibitors in the its aspect of renoprotection and its usage in the nephrology, and how can physicians be aware of its importance while managing the type 2 diabetes mellitus. And as rightly said by you, that the SGLT2 inhibitors are now have become the cornerstone as second line therapy, especially in the patients who have the increased risk of cardiovascular and the increased risk of renal compromise, as well as it is also approved in the CKD. So I would like to ask participant to add their questions in the Q&A box. So we would be able to. So Dr. Abhi, is there what point should be considered before prescribing SGLT2 inhibitors to an elderly patient?
Okay, so first of all, I must say that even SGLT2 inhibitors are safe in elderly age group as well. But there are certain points which need to be considered, especially volume depletion has been seen as an important component which needs to be taken care of, especially SGLT2 inhibitors have shown to have some concern in patients who are volume depleted. So before starting, we should have a clear-cut idea that the patient is volume deplete and doesn't have overt volume depletion. That is the first thing, and of course, we have to tailor their therapy. Some small individual experiences have shown that they might cause to small extent certain amount of hypoglycemia as well, which is of course not very common. And so I think there is no overt concern. It has to be individualized and it has to be properly monitored in the early days. And of course, if we are talking about elderly and especially elderly females, then in postmenopausal females, there is a concern that there could be increased genitourinary infections and of certain fungal infections, but most of these side effects are reversible.
Right. The second question, that which monitoring parameters needs to be monitored or important during usage of SGLT2I?
Look, I mean, we don't have any separate specific monitoring parameters for SGLT2 inhibitors. These are reasonably safe drugs, but the same things that we normally have used for a diabetic kidney disease patient, or for that matter is chronic kidney disease patients, we have to look into how effective they are in controlling the blood sugar of a patient. First of all, if the patient is already on some anti-hypoglycemic agent, So we might have to reduce the existing antihyperglycemic agents to add on an SGLT2 inhibitors. That is point one. Number two, we have to see how effective they are, at what point of time the dose needs to be titrated, and what point of time we may have to increase or add another drug. That is one point. Second thing, of course, we have to look into other cardiovascular and other systemic involvement and address those concerns, which may not be specific to SGLT2 inhibitors,
Yeah.
but they are more or less necessary because of the multiple organ involvement in a
Yeah.
patient with diabetes.
Yeah. There's a question that, as you said, SGLT2I reduces the intraglomerular pressure. Does it translate into the antiproteinuric effect? The first question is this, and second is that uh, uh, how useful SGLT2I in patients without diabetes, those who are at risk of progression of CKD. So there are two
Yeah,
questions
those
collectively.
are very, very interesting and very good questions. Actually, the largest trial as far as DAPA CKD trial was one of the largest trials which was conducted in patients who had a glomerular filtration rate or low glomerular filtration rate, and those patients who had um, what you call is albuminuria from 300 to 5,000. In these patients, it was seen that dapagliflozin was quite effective in reducing the progression of chronic kidney disease as well as in reducing albuminuria. And another trial, which was published as late as the 4th of November in New England Journal of Medicine, the study came and it was quite a hot topic of discussion of late, was IMPACT kidney trial. And that trial also had shown that these drugs are beneficial. And coming to the second part of the question, whether these drugs are beneficial in patients who do not have diabetes. Yes, these drugs do have been shown to delay the progression of chronic kidney disease, especially dapagliflozin has been shown. And I think the benefits would extend to empagliflozin as well in reducing the progression of chronic kidney disease in patients without diabetes as well.
Yeah. There's one more question. Dr. Chattopadhyay is asking that decay, diabetic ketoacidosis is one of the harmful effect of this. We should not be overlooked. What is your view on it?
Yes, Dr. Chattopadhyay has said a very important concern. Diabetic ketoacidosis has been shown to be a concern in certain areas, but as I told, most of the times we advise these drugs in type 2 diabetes. In type 2 diabetes, diabetic ketoacidosis shouldn't be so much of a concern, and of course, patient needs to be monitored. Volume status is another important area that needs to be monitored in volume depleted patients. And in these patients, especially those who have an active infection, ongoing infection, or patients admitted in an intensive care unit, those who have got other immunocompromised status, in those patients, one needs to be more careful about monitoring these agents where the incidence of diabetic ketoacidosis could be more pronounced. But on a larger scale, in most cases, this is not so much of a concern.
Yeah. One last question for today's session is, uh, how, do you, how do you, prescribe? What is your algorithm to prescribe the SGLT2I? Which type of patients do you go for SGLT2I without diabetes? What is your overall clinical algorithm?
See,
Your own experience?
I must say that much of our experience, mine as well as yours, we are all work in progress as far as SGLT2 inhibitors is concerned, because we have just started prescribing these drugs. We have seen the early results, but to have a declared algorithm that my algorithm is the final, my way is final and your way is not, it's not the right thing. You have to individually titrate, but increasingly I am trying to add on in SGLT2 inhibitors wherever I can. And in some cases, in patients who are in early CKD who do not have diabetes also, I have started prescribing these agents. My patients are doing stable, but these are still early days.
Yeah.
And I wouldn't draw any significant
Yeah,
conclusions.
yeah.
I think they would be doing well.
Right. We appreciate your views on this, and I think all participants, they are getting benefit out of your today's presentation and the question answer session. I would still give 1 minute. If you have any questions, please do ask, and we can. Otherwise, we'll close the session. Yeah. So there are no more questions, sir. We have our colleague from marketing team, Mr. Rahul Kasbe. He has been handling the CVM portfolio along with SGLT2I inhibitors. So he's instrumental in launching the dapagliflozin also. So I would request him to, this is one of the greatest opportunity that we have, Dr. Sukanto Das from Amra Institute with us. So it's Rahul's pleasure and our pleasure to deliver vote of thanks.
Sure. Thank you, Dr. Mangesh, sir. And I'm really privileged and honored to be the part of this kind of a conversation. And I'd like to thank you, Dr. Sukant, sir, to enlighten us for the dapagliflozin, and definitely to all the participants and all the physicians get another view about our dapagliflozin, which is the upcoming, golden molecule, I would say, in terms of diabetic treatments. And definitely it will be going to help to the prescribe their from tomorrow's there is a new patient for the dapagliflozin in terms of a CKD. And also I'd like to thank you for all these participants who joined for this sessions, and definitely will connect with you if you have any query with us. So again, I'd like to thank you from the team RPG and from these wonderful sessions.
So what is your final remarks, and you can close?
Okay, first of all, before my concluding remarks, thank you, Dr. Mangesh, and thank you, Rahul. And talking about SGLT2 inhibitors, these are promising agents. They hold a lot of hope. I just hope and pray that they would live up to the expectations, the hype. We all have been waiting for an agent that can reduce the progression of chronic kidney disease. And this, if in the long run, all these expected benefits that we have ascertained or derived from studies is going to be seen in the population, this will be a significant step forward in reducing the progression of chronic kidney disease in diabetes. And diabetes being the most common case of chronic kidney disease, if can reduce the progression of diabetic kidney disease, then there is nothing like it. But there are certain populations in diabetes, in kidney transplant patients, in ADP-KD patients, their role needs to be re-established. So having said that, they are very promising, and let's hope that we'll have more and more studies to document how beneficial they are. And in the meantime, let's all use our individual ideas, our individual opinions, and our individual insights in using this molecule so that we can gain our own experience and incorporate our own experience and share with others. And I'm looking forward to many more sessions like this to enlighten. It's a learning experience for me as well by sharing this precious ideas and thoughts with such an erudite audience, and my co-panelists, Dr. Mangesh and as well as Mr. Rahul. Thank you.
Thank you so much. Good night. We'll catch up once again. Thank you.
Thank you, sir.